So, hi everybody, and I'm going to go over today for CF EMS how we do things for clinical rotations. Going to be a little bit of a lengthy video, but there's some things that you need to understand coming into clinicals, and you're going to be learning some of these things as you go along. So, first and foremost, don't ever panic. I want to stress that point very, very, very clearly. All right, so with that being said, let's move on to some things that you're going to need to know. And I'm going to also pull back the curtain a little bit about we're going to talk about the student minimum competencies, which every paramedic has to do. And when you first see it, you'll be overwhelmed, but I'm going to walk you through it. So we're going to talk about what things are and are not allowed to do at clinicals. We're going to talk about the different types of clinicals. We're going to talk about how you're going to input the documentation in the field. I'm not going to get very specific on the platinum part of it because that's going to be a whole different class and a whole different video. So again, we're going to talk about getting to the clinicals, you physically getting there, what you need to do, what you need to say, what you need to let them know about, what to do in case that there is an emergency at your clinical and things happen, and needle sticks is our number one thing that we get, and those are evil. We don't want to do that. And last but not least is the learning tips. We're going to, again, how to input things in the Platinum Planner to get the most out of it. And I will tell you, after you chart a couple times in Platinum, come back and watch this video. It'll probably make a lot more sense. All right. Moving forward. All right, so some general rules. When you get there, you're going to arrive at your clinical and make sure that you know where you're going ahead of time. We put the address in there, but also ask your instructors, like if you're going to an emergency room, you come in the front entrance. If you're going to one of the freestandings, you'll still go in the front entrance. If you're going to respiratory, you'll go up to the second floor where the respiratory is. And make sure that you talk with your instructor about that so that you know exactly where you're going and what you're doing, okay? Park in the right spot. Folks, there is designated parking that the clinical coordinator will go over with you. Park in those spots. Don't try to sneak up to the front parking spaces. I constantly get phone calls about that, and I will tell you, don't do it. It just keeps us out of trouble. All right. Or again, get there about 15 minutes early. Introduce yourself to everybody. Tell them who you are and where you're from, and again, and why you're there. If you're here for an OB clinical, or you're there for a ER clinical or a fast track clinical. So you need to do that. And last but not least, and I can't stress this one enough, no matter what happens on a clinical, be nice. Because I will tell you, the number one thing that I have to deal with is people that are not nice to you guys, and when you're not nice back, or you started out not nice, there's really no defense. Pretty much, I'm going to say, yeah, you shouldn't have done that. But if somebody is mean or bad or mad at you, then again. All right. So if emergency rooms, you're going to do 120 hours of those. And one of those is going to be a physician shadow, and it's going to be very specifically labeled that. We'll go into that a little bit here in a few minutes. There is one fast track video, one fast track clinical. I will tell you that we're probably going to be phasing that out within not too long. You're going to do one respiratory clinical for one 8-hour shift, and then anesthesia in the operating room. That is another 8-hour shift. But I will warn you guys, that one usually starts at 6 o'clock in the morning. So again, being on time, of course, very important for that one. All right, so our goals in first semester is to have 50 patient interactions, getting assessments on people. We're going to start at least 25 IVs. We need to get 2 live intubations. Now, here's my little thing about intubations. Never pass up a chance to intubate. And whatever you do, again, more is better on that front. So if you can get 10 intubations, we had one student not too long ago, 17 intubations. I don't know how this kid was doing it, but he did an awesome job. So, hey, but again, we got to get at least 2 live ones, okay? And then performing all of your clinical skills, pushing medications, giving an IM injection. These are all examples of those clinical skills. I'm going to show you those in a little bit. Now, we have a few rules that I will tell you, and there's a reason I put Rushmore up here, because there are a couple that are the Mount Rushmores of sins. And if you attempt to do any of these, I can only assure you that it will be very bad for you. The last 2 hours of your ER or fast track clinical is reserved for data input. So that does not mean that you get to leave early, but it does mean, again, if you're needed to help with something, let's say a really bad patient comes in, you might have to put your documentation down and actually go help somebody. Now, that doesn't mean you go clean the bedpans for everybody. That's not what these last 2 hours are for. Last 2 hours are for exactly what I just said, documentation. And again, there are some times at any clinical that you may need to be moved, both either in the department or within the hospital even. My statement on that is semper gumby. Always be flexible, okay? You do get an hour lunch, and I recommend that you take that hour lunch, and you need to, do that. Just make sure the ER staff knows that you're doing it, okay? Let the charge nurse know, let your preceptor know that you've been assigned to that day. And you can't, by the way, save it up for the beginning or the end of the shift. If your shift starts at 9 in the morning, you can't come in at 10 and say, well, that was my lunch. No, you can't do that. You need to take the break sometime, I would say, between 10 and 2 during that shift, okay? So bad conduct is going to always end up with the clinical site calling me. And they all have my phone number, and they all have probably your instructor's phone number. And I will tell you that if you have done something that is bad in the realm of conduct, you've thrown something at somebody, you have cussed out somebody, there is 100% chance I'm going to get a phone call. If you've acted up, you might as well go ahead and pack your stuff because you're going to be home, because I promise you, if I get there, it's really going to be a bad day for you. Don't do it. Let's try not to do that. Let's try it again. Remember that statement I said earlier, be nice. Okay. Some words of warning. You never know when I or someone else from the college may show up and say hi. That's right. At 3 o'clock in the morning, I have been known to pop my head in. I get a little insomnia. I decide to take a little walk. Okay. So everybody, and I mean everybody, knows how to contact us. And I don't know what it is about Perry, Georgia. Perry, Georgia seems like every time I'm going through that town, I get a phone call. I don't know what it is. But I like speed through Perry, Georgia because I know I'm going to get a phone call. So leaving early or showing up late will always happen when I am standing there, okay, or one of your teachers is standing there. Again, if you show up late, my simple answer is have a good day. So, but if I know that you're going to show up late, please call your instructor and let them know. They will let us know. And the point is you need to be on time. If you're not on time, that's a problem. Falsifying documentation. If you decide that, hey, I need 2 more OB calls, and you decide to make up 2 OB patients. This is a gentle reminder that we do have the ability to audit that. And I would definitely not do that, because I will tell you that it is like the #1 Mount Rushmore of sins is to falsify documentation. You will be dismissed from the program, period. No ifs, no ands, or buts. And I can assure you, if I start asking you questions about it, there's 100% chance I've already got the answer. So again, be careful when you do that, all right? Platinum has geolocation for a reason. When you're going to go in and you're going to go into your clinical, one of the things you have to do is you have to sign in on Platinum. And it's going to say, hey, I want to see your location. Now, you need to say, it's okay for me to see the location, because what that's going to do is geolocate you and stamp you as there at that location. So we have proof that you were absolutely there. And I will tell you that if you decide to skip that little fact, there is 100% chance I'm probably going to come see you, come call you. The point is if you are attempting to get away with something, that immediately puts you on my radar. And that's not where you want to be, okay? Quick word on the medicines and the procedures. Again, anytime you're doing a procedure, a skill, there needs to be a staff member of equal or greater rank than your skill level that you're being trained at. So in other words, if you're pushing a med, there should probably be a nurse there, a doctor, PA, somebody there making sure that everything goes okay. When you're given in a medicine, you will always have a nurse or higher present with you, okay? They will also verify the 5 R's, which we remember from EMT school. Again, making sure you got the right drug, right dose, right patient, right route, right time. Usually the right time is right then and there. I will tell you that if you make that type of error, that's one of those Mount Rushmore sins, gang. You will probably be tossed for that, all right? And again, make sure that you've got somebody there with you. Do not be pushing a med by yourself. I can name 5 instances here when that's happened, and I will tell you that it is pretty much dismissal from the program. All right? These medicines can kill people. Let's not kill people. All right. Going back to you'll never, and I mean never, perform a skill that you have not been cleared to do. You will never, and I mean never, perform a skill that you have been told not to do. I'm trying to think of a good, pericardial synthesis. We haven't taught you that. We haven't told you how to stick a needle in somebody's heart. Because we haven't told you that, we haven't signed you off on that, we haven't checked your skills on that, you should never, ever, 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 ever be doing it, okay? And if you're performing a skill, there should probably be somebody there to supervise you, okay? So you will never, and I mean never, do that without supervision. All right, next up on the docket. So again, fast track. This is usually a really simple patients. Usually got a high volume of patients, lots of IV starts, lots of assessments. And it usually starts at 11 a.m. instead of 9. But I'm going to tell you again, we are probably going to be phasing this out and phasing it into another emergency room clinical, just so you guys are aware of this. Fast track has kind of gone the way of the dodo. It's time for the program to evolve, and we're going to evolve with it. When you are in fast track, though, what I want you to really focus on is getting your assessments. And boy, is it a great place to get your IM medicines. And if somebody says they need a tetanus shot, it's going in the muscle. You remember, you got to have 2 of these guys, okay? And so again, the medication pushes or administrations, they also do a lot of those in the fast tracks. All right, there are 2 big types of emergency rooms. There's the ones at the hospitals, and then there are the ones at the freestandings. You have to do 120 hours of clinicals during your first semester. Okay, that's 12 10-hour shifts. Okay, you're basically looking at doing 2 clinicals a week while you're in first semester. Remember that you do have the last 2 hours to document, and I want to stress that point. And so when I get a report from you that's only got 1 or 2 patients on it, I know most ERs in this area see somewhere around 100 patients in a 12-hour period. So for you to say that it wasn't busy, I've not been my experience, I will tell you that. Now, some of even the freestandings guys are getting 50 to 60 patients in that time frame. So again, you can get good quality interactions with them. All right. Again, this is just a reminder of all the times, okay, which you're going to document from 5 to 7. You're going to document from 0300 to 500 if you're doing a night clinical, okay? Don't overlook those freestandings, though, because, boy, for some reason, they send kids come in there a lot. Pediatrics. You got to have 30 pediatrics while you're in the program. And the more that you can get there, the less you have to get in Peds ER. And believe me, that's coming in second semester. And if you see a kid involved in a kid, please go to them because it's a really good patient to get. Again, these freestandings usually get lower acuity patients, so you get a little bit more assessment time and interaction time with them. And however, though, we get people that show up to those and are really sick. And at that point, I'm going to tell you, you're probably going to get to do a lot of stuff because, again, the freestanding ERs are staffed a little bit differently, so you're going to have a lot more interaction. And it is usually a little bit, I wouldn't say a slower pace, but a more controlled pace. It's a little bit more laid back there. But again, if you do a lot of them at the freestanding, just remember you might miss out on some patients that you would normally get at the big ERs. So, and by the way, sometimes they let you do things that maybe you're not supposed to do. If you're not supposed to do it, remember that's a never, 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 ever sin. Okay, so we don't do that. Again, our goals in the emergency department: assist the staff, assess your patients. The more you can assess, the better. The more that you learn the rights and the wrongs of what's going on with a patient, and learn about the pathophysiology, what's causing the problem, and how do you fix it. You'll be surprised. Learn the patho, and this job gets really easy. Okay, but you're going to do a lot of procedures as well. IV starts, 12 lead EKGs, IMs, IUs. Now remember, in first semester, we haven't taught you cardiology yet. So you're going to be putting the stickers on, but you're not necessarily going to understand and interpret what they mean. Don't worry, it's coming. All right. There is one physician shadow that we are going to do. All right. These are specifically at Ocala Regional, and you will be shadowing either the attending or a resident or Dr. Fraunfelter himself, which is our medical director. And if it, again, these are still being phased in. So if this will take the place of one of your emergency room clinicals. But boy, I can't stress enough, boy, this is an incredible opportunity. Please take full advantage while you're doing that. And especially if you get with Dr. Frank, he's going to want to know, can you form what you think is going on and then form your treatment plans? And they're going to ask you for this course of action, okay? Because Dr. Frank has briefed all of his residents and all of his attendings on this when you're doing these shadows, okay? They're going to know they're in an emergency room resident. They are doing their version of a capstone. Okay, so they're learning the job as well, but that's what they're going to learn. That they're learning how to teach you how to become a better paramedic. Okay, so that's part of their job there. All right. And by the way, we're still seeing what works and what maybe didn't work. So we're definitely going to be trying to get your feedback on these clinicals. Absolutely. All right. So now what patients do you need? Now at this point, I'm going to bring up something. We'll come back to this guy. Let's see here. And this is our little secret hidden thing here. So gang, here we go. And I'm going to bring this up. And we're going to go to what? And I pulled up the wrong one. I'm sorry, guys. So let's go back to this one. There we go. That's what we need. All right. So this is actually the backside of Platinum Planner. And these are the number of hours that you need for every little category. Now, don't panic. We're going to get to these. This is for all of them. Again, 176 hours for first semester. 100, again, phase 2, phase 3. So all of these things, there's different levels that you're going to be doing, okay? So don't freak out. There's plenty of hours to go around. But here's the part I want to definitely focus on. And again, every time that you do a skill, again, most of these are going to be batch graded in the lab. So that's not something that we're going to have to worry about. But clinical skills. Now, we're going to earn some of these while you're doing your scenarios here at the school. To be very specific, the name scenarios that we do will all count towards some of your clinical skills, okay? But there are some of them that you're not allowed to get during the sim, and that's the point I want to stress here. So then I'm going to give you an example. You have to have 2 IM injections. You have to see 20 patients that are where you have competency in what you did, but you also got to see 30 adults, gang, where you're learning how to do the assessments, okay? So, and that brings up formative versus competency. Folks, we always do formative before competency. I'm going to stress that again. We always do formative before competency. And I will tell you that if you can see over here, it has a max of how many, and we set it up this way on purpose. And the only ones that we didn't set up like that is going to be your pediatrics. So that's the only ones you got to really take a good close look at. But these are, you got to have a number, you got to assess so many abdominal patients. You got to assess chest pains. And by the way, this is all going to be in your report. And I'm going to show you how to get to there in just a second. And again, you have to cover every one of these. Now, like I said, some of these are actually are going to be as part of your scenario-based stuff that we're going to do in lab. But a lot of it, I will tell you, is not. And the more of these that you can knock out while you're at clinical, please do so, okay? You definitely want to do that while you're at clinical, okay? You got to see so many trauma patients. You got to see that. And again, remember those kids? Well, we've got to have 30 of them in total, but we have to have 2 of each particular age group, and that is a requirement that we do that, okay? And these are what are called COAMPS requirements, which is our accrediting body that says that. All right, real quick on team lead and team member. Team member is when you're on the ambulance, and those are when you're doing your formative ride, second semester and the very first part of third semester. Your team lead, not the formative, but the capstone part of it, then you have to have 30 of those where you're actually a team leader during the capstone, and that is a requirement. So again, we don't usually use team lead competency until we get to our third semester. Enough said on that. All right. So again, all of these skills you're going to have to get over the course of time. And by the way, it looks like a lot. If only we had a way to track that. Oh, wait a minute. We do. And this is what we do when we talk about, I'm going to close this up so we can get to the right spot. Go back to my dashboard and let's see here. And I'm going to borrow Paul's, or actually one of the other classes. Let's see here. And just to show you what it looks like at the end of a first semester. So again, and I'm going to pick Miss Lou's class because she is the one that just finished when I made this video. And we run the report, and then this is going to tell us exactly where they're at, okay? And how much has been done for everything that they've done in the class and in the program, okay? And again, notice how we've got some people that, again, they had some folks that didn't pass the class, so that they have to go back in and take these in or put these out. But again, this is for the entire cohort, but you can actually pull this up. And I'm gonna borrow a student here. So let's see here. I'm gonna borrow Miss Amelia. She's in the second semester class, and I'm gonna kill her lab skills because we don't need to see those. But again, this is everything that she has done as far as her ride time. Notice, like I said, she's just finishing second semester, so she hadn't even started that capstone yet. But if you look down here, these are all the things that she's going to have to do. She still has to get 6 more adult patients. That one's pretty easy to do. She's got most of her adolescent, again, most of her pediatric patients, and you're going to learn which one goes in which container, by the way. That we're going to learn that when we talk about age group and development, growth and development during your class. Again, notice how she's still got to get a couple altered mental status patients. She's got to get a couple more chest pains. So again, any chance that you get, by the way, she only had to have 2 intubations and she had actually 5. And by the way, when you see this adjusted column, this is the things that we can go in and override, and we kind of don't like to do that. We would prefer it to be filled out by you, okay? And like I said, she's already got 131 out of 150 of her patients that she's going to need for totals. But she has a very clear look at exactly what she needs at all times. And by the way, a lot of these, especially if it says SIM requirement, those guys are going to be done during the lab session, so don't panic about those. But run that report before you, like when you get there at the start of the day, run this report to see that what you need, especially after you got a couple clinicals under your belt. The goal in life is to reach 100% on all of this. You will not graduate until you have 100% on all of this. All right. So, talked about going to planner. Let's see here. All right. Again, formative and competency, just as a reminder. Formative is you're learning the skill. Competency means that you have mastered it. You can do it with little or no supervision. And you always get formative before competency. I can't say that enough. Always formative before competency, okay? All right, especially in pediatrics, you're going to have to really keep a close eye on those, all right? All right. These are going to be highly interactive clinicals. Get your assessments. Get your IV starts, okay? Help out, because when you help the staff there, they're going to help you, especially when it comes time to do something really cool, like intubate or push meds or work a cardiac arrest. And make sure you get your signatures, okay? And when you get done at the end of the clinical, what you're going to do is hand the preceptor your device, and it's going to have the little form. They're going to fill out the form, they're going to sign it, and they're going to hit submit. All right. And when they do that, again, make sure that it's somebody who actually precepted you, or the charge nurse, or whoever was in charge at that station that day. Again, whoever was primarily watching over you. What I do not want to see is the secretary's signature. If I see the secretary's signature, you're going to get that report back and you're going to have to go fix it. Okay? All right. So, respiratory clinicals, 8-hour shifts. All right. You're going to show up. It's the second floor. Advent is usually where we do these, but we also do some over at Citrus. But again, you're going to do an 8-hour shift with a respiratory therapist. Again, remember, we're looking to assess lung sounds, okay? Get your respiratory assessments. These guys are experts at it. Learn from them how to do a proper lung assessment, okay? You're going to do a lot of nebs, passive nebs or work here. We get a lot of these in the ER too, so don't panic if you don't get any. And again, this might be a good time for you to get a chance to interact with ventilators, ET tubes, especially into tracheal suctioning. These are really good things to do and really good things to learn, okay? Do we have to do an assessment on every patient? You can, but I will tell you they're usually really faster paced. But if you're given a neb, I would definitely assess that patient first. I want to listen. I want to do that. Do we intubate and respiratory? If there's a doctor there and they're willing to let you do it, seize the day and absolutely do it. Okay, if they're going to let you, go for it. All right. Can we do ET suctioning? Yes, but make sure that the respiratory therapist is going to guide you. First time you do it, it's a little scary. Okay. And should you have at least one patient on the respiratory clinical? Well, yeah, because that's how you're going to get the respiratory patients. It's probably a good idea that you chart them. All right. So again, you're going to listen to lungs, do good respiratory assessments, give nebs as you get a chance, and then, and by the way, sometimes you're going to get a dud for the respiratory therapist. It happens. Don't panic when that happens. Don't worry. We're going to get your skills. Do what you can. Do the best you can with what you've been given. And most of them, by the way, they know what you need, and they're usually very helpful. Anesthesia. All right. Let's talk about the OR. Because, again, boy, this is where we get our live intubations, okay? And I will tell you that we've got a absolute ton of good responses for anesthesia. That they really do like us in there. I will tell you, every now and then we get a doc who's less than enthusiastic, but I will tell you, for the most part, we've got a great set of anesthesiologists, absolutely, and they work very hard. And learn from these people, okay? Learn from these anesthesiologists if they're going to let you, and show your eagerness to learn. This is a really great place in the fact that you can actually go and get an assessment on your patient before you intubate them. Usually when we're intubating, we don't get an assessment. Our assessment is they're not breathing and I need to put a tube in their throat. Okay. So you need to go to the OR. You need to make sure you introduce yourself. You're going to get into OR attire. Okay. And sterility. Sterility is a big issue, folks. We don't drop things. If something fell on the floor, guess what? We don't use it ever again. All right. Clean, and they're going to show you how to scrub in. They're going to show you how to wash in. And there is a very specific thing that you need to do with that, okay? Sterility is a really big thing. Remember, we're opening these folks up, and although we do a lot better than we did maybe 30, 40 years ago, we still subject patient germs. We want to minimize that, all right? Again, sometimes we get super awesome, and every now and then we get some guys that are duds, okay? They're probably not going to let you do IV starts, and they're probably not going to let you do anything else except airway. All right. And so again, you're going to always have somebody with you. And again, you're going to follow directions. If you freelance in the ER or the OR, good luck. I'm going to find out about it. I promise. Don't wander off. And again, remember, when we speak to somebody, it would be Dr., Miss, Mr. Again, we are going to use really good OR theater decorum during this time, all right? We don't, if the doctor's name is Frank Fraunfelter, we don't say, "Hey Frank, how you?" That's not a no. It's Dr. Fraunfelter. Again, good decorum here is very good. All right. Be respectful. Let the anesthesiologist decide whether or not you're going to tube or not, and let them decide. Let them do all the questionings. Okay, especially on a pre-op interview. Let them go in, but you need to listen because it's amazing what you're going to learn just by sitting there and watching and listening. And by the way, they might say no. And if they say no, that's okay. Again, you can just ask, hey, can I come in with you when you do your pre-op interview with them, when you do your pre-op assessment? And I will tell you, again, it's a good habit to do because they're going to ask all the questions that, when given the chance, it's a really good thing to know about a patient. All right. Again, follow the directions, watch the team. Okay. And by the way, I recommend watch, then do. All right. Sometimes they might just hand you the video scope. Sometimes they might not. But again, watch, then do. Okay. All right. So a couple Q&A questions about the OR. The team's not letting me do anything. Can I leave? All right. If they've stuck you in the corner and they're not even letting you observe, you need to contact the clinical coordinator, your lead instructor. More than likely, you're going to have to redo this clinical. All right. All they're doing that day is supraglottic airways. Is this okay? Yeah, because in my opinion, you should never pass up a good chance to do an airway. All right. Can I leave after my 2 intubations are done? If you're asking this question, you're probably in the wrong school. Okay, because more is better. Guys, any chance you get to do a live intubation, okay, that is more practice so that you might be able to save somebody's life. Yeah, the more you can do, the better of this, guys. I think the current record is 23. And, hey, I'm all about you guys breaking that record, okay? What if all the cases are done for the day? All right, you can get your signatures and you're going to mark that you were there for this is a great time to document everything that you just did. Just throwing that out there, okay? Again, keep it sterile when you're in the OR theater, okay? You can watch and try to do the pre-op interview if you can. And when you show interest, you'll be surprised. And if you're good, you'll be surprised how many more intubations you're going to get. The one thing I will tell you is, though, if you show your tushy in there, you have some bad conduct, I will tell you that is on the Mount Rushmore of sins, okay? So please, please, please don't do that. All right. That's all of them. It's all the things, but I am going to remind you again, clinicals are what you make them. If you stand in the corner and do nothing, guess what? Your clinical experience is probably going to be horrible, okay? The more you get in there, the more you do, the more they let you do. Now, there are certain clinicals, especially when we get to second semester, that are more we're going to observe. But I'm telling you, when you're in an OR, you're in an ER, respiratory, I'm telling you right now, the more involved you are, the more they're going to let you do, okay? And then get these procedures, these IVs, the IM, the med pushes, med infusions, get all of these done and taken care of while you're in the ER, okay? If you have any questions, and you're going to have questions, and it's okay to have questions, first stop's going to be your lead instructor. Second stop, or equal to that first stop, clinical coordinator. All right. Again, when you get assigned to that preceptor, talk to the preceptor. If you've got questions, ask the preceptor. They were students once too. And again, every now and then we get a preceptor who's less than enthusiastic about being there. And that's okay. If you just let us know, we can handle those things, okay? But again, be nice. And again, if you're having problems, let your lead instructor know. Please let your lead instructor know. Part 2 to that is that if it's still bad, they'll definitely bring it to my attention. I know their bosses. I know their bosses very well. I have zero problem bringing them information, okay? And again, folks, by the way, one of the things you're going to do when you're documenting is they're going to fill out your evaluation. But the other thing that you do is you write out an evaluation on them. And so if you're not having a good experience, put down the reasons. And I assure you, I share those with the nurse manager. And I can also assure you that, yeah, they really like that kind of feedback, because I can guarantee you, if they're being bad to you, they're probably being bad to everybody else. And because they're being bad to everybody else, that's a behavior that we want to correct. Okay, but again, listen to your preceptors. Always be nice. All right. But again, if you have any questions, again, remember that your lead instructor first, BJ to help, and then I'm here to help guide those things as well. All right, that's it for this video. I know it's 35 minutes long. Ooh, I went a little bit long, and it happens. Again, you're going to have questions as you go into this. It's okay. Well, once you get a couple clinicals in, we'll come back and we'll talk about the documentation part of it, because that's going to be an ongoing process. The more that you can put down as far as skills or design, better. Okay. The more that you can do, the better. The sooner you can get those knocked out, the better. So take a look at those skills that you're going to have to do and try to knock them out as soon as you can. All right. With that being said, that's the end of the video, and good luck on your clinicals, and we'll see you on the next one.